Woo! Thank you, Rosa. Good evening, everyone, and welcome to our live webinar, Advancements in Ultrasound Technology. I'm Dr. Jonathan Paris, and I'm honored to be your moderator here tonight. While the sun might be setting here on the East Coast by me, I can assure you the party has just started. Whether you're joining us from across the country or across the globe, we're thrilled to have you here. This event is hosted in collaboration with two major multidisciplinary pain and spine societies, the Pacific Spine and Pain Society, or PSPS, and the World Academy of Pain Medicine United, or WAPMU, which is quite fun to say. Today features a distinguished lineup of expert panelists, each bringing unique insights and clinical expertise. They will be properly introduced in the coming minutes. Tonight we'll be exploring the cutting edge of ultrasound's role in diagnostics, pain management, and procedural techniques. So buckle up, because you're in for an exciting ride and into the future of this exponentially growing field. We encourage you to participate via the Q&A chats and polls throughout the evening, as one winner will be awarded a free conference registration to the next WAPMU conference. Lastly, thank you Sprint Therapeutics for sponsoring this webinar. Well, let's get right into it then. Let's dive into innovations reshaping medical imaging and discover what's next, starting with our first panelist, Dr. Robin Mata. Dr. Mata is a physiatrist and interventional pain fellow at Rush University Medical Center in Chicago. She serves on multiple professional society committees for research and education within the neuromodulation space. Her research interests focus on enhancing safety and patient outcomes through clinical research and neuromodulation, as well as contributing to evidence-based guidelines that inform clinicians' decision-making. Let's get some applause in the chat for Dr. Mata.
Thank you for a wonderful introduction, Dr. Paris. I love the enthusiasm, and thank you for having me. So we're going to start this star-studded panel off tonight with a basic overview of ultrasound and kind of lay the framework for some of the more advanced topics that our speakers will be covering. So starting with what is ultrasound? It's essentially taking high-frequency sound waves to create real-time images of internal body structures. Ultrasound has a lot of unique advantages, which is why it's become so attractive. It's non-invasive, there's no radiation. We can see our images in real time. For the most part, it's pretty portable, and compared to other imaging modalities, it's relatively inexpensive. And for that reason, it's used pretty commonly. We use it for pregnancy monitoring, abdominal imaging, cardiac imaging, and for the purposes of tonight's discussion, musculoskeletal assessment. So at the bottom, you can see the basic concept. You're sending high-frequency sound waves towards an object. Some of those sound waves are being reflected back, and that's being picked up by the receiver. Next slide, please. And so what is doing that? That would be the transducer. So the most commonly encountered part of the ultrasound machine that you'll see is the transducer. So if you see on the bottom right, it's what's generating and picking up those sound waves. There are different types of transducers. Most commonly for MSK, we're using the linear and the convex. So linear is going to show us more superficial structures. The convex is going to be for visualizing deeper structures. There are other types like the phased array and the endocavitary, just to be aware of. So once we generate those sound waves, they are traveling through the tissues. And so if you look at the bottom image here, you can see that based on the tissue or type of medium that those sound waves are encountering, the sound waves behave differently. So sometimes when they're reflected back as echoes, depending on the medium, that's being picked up by the transducer, and then that's transmitted to the computer, which is ultimately producing the images that we see on the screen. Next slide. Ultrasound can be pretty simple when we think about it from that high-level overview, but if we start to get more in the details, we see that it's really on a spectrum that it exists. So when we think about sounds, low-level sounds that we can't pick up as humans, things like earthquakes, volcanoes, the shift of the tectonic plates. Beyond that, we have the range of audible human sounds from 16 hertz up to 18 kilohertz. Past that is what's considered ultrasound. And even further into that, you have a lower range, like the power ultrasound range. And at the very high end, we have what's called high frequency ultrasound. Next slide. So again, if we take this from a more simplistic view, most people think of those polar opposites of the spectrum, with the lower end being for diagnostic ultrasound. So low energy waves that we're just sending out to bounce back and create images. And then we have therapeutic ultrasound, which is more of the higher energy waves. So here, because there's more energy in those waves, they are actually disrupting and interacting with the tissues. It's causing physical and chemical changes. And while ultrasound is used outside of medicine for a number of applications, here we can think about it as sort of burning. Next slide, please. So it gets a little bit more detailed. Not necessarily all low frequency is just diagnostic. It can also be therapeutic. So there is what's called low intensity ultrasound therapy. The idea here is that that lower amount of energy is subtly promoting healing and reducing inflammation. Things like soft tissue injuries, bone fracture healing. Next, compare that to the high frequency ultrasound, the polar opposite, where we're taking a very precise focused beam of that high energy waveform, and now we're focusing it on a tissue to disrupt or physically or chemically change it. Think about ablating tumors without incision. So things like fibroid removal, prostate cancer removal. Next slide. Why is ultrasound so exciting in interventional pain management? I think a lot of it comes down to the real-time imaging capability. So when we're using fluoro, we, place our needle, take a picture, advance our needle, and then adjust from there. With ultrasound, we can really see exactly where our needle is inside our target tissue at all times, as long as we're right over that needle. So because of that, we're more accurate, which means we have less complications. We're targeting our specific tissues and we're placing our medication exactly where it needs to go. It's also pretty versatile and it's evolving. So beyond those basic diagnostic scans and some of the therapeutic interventions, it's constantly being improved upon. So we're seeing more miniature versions, more portable, easily accessible versions of ultrasound coming out. Now we have AI being integrated into the image analysis portion. And then beyond those basic therapeutic applications we discussed, there's even more potential applications that are coming out. So with that basic knowledge, we're going to go forward into tonight's lecture, starting with our first distinguished speaker, Dr. Gofeld.
Well said, Dr. Mata, truly. Next, we move on to one of the four founders of WAPMU, formerly known as the American Academy of Pain Medicine Ultrasound. He's a preeminent educator in ultrasound guidance in both regional anesthesia and pain medicine. He's currently in private practice in Canada, but he's been at the University of Washington as senior faculty. He's been around the world as a leader in ultrasound guidance, both in diagnostics and therapeutics. He's a founder of the certification for international pain sonographers, which is the exam that the WIP uses. He is an executive advisor to FUS Mobile. He's one of the four founders of ultrasound guidance and pain medicine with his current research in high intensity frequency ultrasound. Let's get some applause in the chat for Dr. Michael Gofeld.
Thank you, Jonathan, for a kind introduction. So I'll try to cover in my 12 minutes a topic that usually takes about 40 plus minutes. And I will talk about a recent innovation in the technology that allowed us, interventional pain physicians, use high frequency ultrasound in our practice. Next slide, please. So everyone played magnifying glass, probably multiple times. If not, I strongly advise you to try it. But we never thought that other types of energy can be focused and create the same lesion, such as electromagnetic field, or for our instance, our discussion, ultrasound beams. And William Fry, and actually it was brother Fry, discovered this technology, or discovered this option back in the 1960s when he was in faculty on University of Illinois. And he created this 4-beam high flow applicator first time for neurosurgery. You can imagine how practical it was back in 1960s, where only X-ray was available, barely, and multiple calculations were needed to advance this beam to treat tumors in the brain. But fast forward, next slide, we have some advanced technology, and one of there are few available, but the most commonly used is MR guided, ultrasound guided. And over the past 20 years, this technology has developed to the point that we treat microscopic tissues. The treatment is approved by, at least as far as I know, by FDA and Health Canada for treatment of essential tremor and probably Parkinson is coming up, and as well as approved but not in the mainstream for tumors, for bone ablations, for soft tissue ablation, etc. The principle is to create a bifocal beam of ultrasound sonication guided by MRI, whereas also sensor of temperatures is included, and this is a very advanced technology, as you can imagine, and the challenge here that it is really not accessible to most of the practitioners, even not radiologists, let alone pain physicians. The challenges are obvious, starting from the cost of the technology itself with all scanners and the emitters associated is $1.5 million of dollars. It's a long treatment. Some procedures take up to 3 to 4 hours. There's need in immobilization, general anesthesia, heavy sedation, etc. The cost is enormous of the treatment as well. So with all this, it's been a progress and enormous enthusiasm to use MR guided technology, including spine applications. And recently it was a case report published in Mayo, but it's been not just in the Mayo Clinic, but other places in the world tried using MR guided for spine. Fast forward, next slide. But what if the machine is miniaturized and the imaging from MR turns to be a familiar fluoroscopy? The operation becomes intuitive and the efficacy is similar or even exceeding radio frequency. Next slide, please. Before we dive in it, we need to talk a little bit about physics. So as I said, MR-guided technologies is based on a bifocal beam, or it's also called coherent beam, coherent sonication, where the beam is so much precisely focused on a certain point that it creates a lesion just there, and it's kind of graying. It can be created in multiple lesions, but basically it's focused on a specific spot. Now, contrary to that, there's another mode which is called incoherent sonication, where the multiple sonication rings, they interfere with each other and create sort of a space, which is arbitrarily about a couple of inches length, and within this length, only if the beam hits a bone tissue or any other surface, hard surface, it will create a lesion. So on a slide, you can see on the left side, if the focus is far away or a little bit away from the bone tissues, it will create some lesion. If it's beyond the bone surface, it also create the lesion. But if it's in soft tissue without any bone interference, it will create no damage because it will focus and then defocus and dissipate. That's basically is in a simple way to present incoherent high frequency ultrasound. Next slide, please. So if it hits the bone, it will create a horseshoe sort of shape lesion, and that's about 1 centimeter in the base. fairly similar to cooled radio frequency, except it will be more precise, and I will show you why. Next slide, please. So when we embark on this adventure of focus ultrasound with a more miniature and simplified device, we had to convince ourselves, and it's also regulatory bodies, that it is at least equal to radio frequency. So one of our first experiments was to compare side by side HIFU and radio frequency. We use standard radio frequency with 18 gauge curved cannula, and it was a pig experiment, and it was published last year in Regional Anesthesia Pain Medicine. Next slide, please. And that what we saw is that radio frequency created a lesion. You can see in the a groove between superior articular process and transverse process, and the pig's transverse process is very long. It created a lesion, as well as high intense focused ultrasound and 1,000 joules, and created the lesion. And 2,000 joules, honestly, it was too much because it basically burned the bone as well, but it created a larger lesion. Next slide, please. What is interesting that we confirmed that other people, including Mehul Desai, who just published an article about interference of radio frequency with the bone, was already known, because the radio frequency lesion is kind of bounced out of the bone. And on the left side, you see the slide from a radio frequency with the nerve, unfortunately, still intact. On the right side is a HIFU lesion when the nerve is completely encircled by necrosis. So what we saw, the percentage of ablation nerve was 71, 86, and 96% for increased doses of HIFU, where only 50% it was covered with radio frequency ablation. Next slide, please. And when we think about it, it's quite obvious. Unfortunately, we are not really versed in the basics of radio frequency, other than we know that the temperature will be elevated. But cardiology literature is abundant with studies and theses related to limitations of radio frequency, and radio frequency current can be influenced by multiple factors, including tissue factors, blood flow, impedance, location of the grounding pad. I still kind of don't understand why people place the grounding pad far away from the probe. Metal implants and prosthesis. That's, by the way, I also feel very uncomfortable thinking about radio frequency after knee replacement, because obviously all energy will be absorbed by metal implants. In cardiology, again, radio frequency is used endocardiac, but almost never epicardiac, because there's a fat there, and the fat is a very good insulator. So that's also quoting the whole Desai study here. And obviously, many patients with low back pain have significant fatty atrophy or multifidus muscle. So it's not clear whether we're actually achieving a radio frequency lesion when we do radio frequency. Next slide, please. So this study we had to do because FDA asked us to compare. And to compare, we already had the data with HIFU, but we did not have data with after radio frequency, and that we created. So we put patients after routine radio frequency through MRI, and radiological evidence of ablation and edema was only 20% of ablation and 44% of edema, which is fairly similar to a pig study. And degree of multifidus atrophy negatively correlated with MRI finding, which is also not was shockingly surprised, because that was already known from basic biophysics. Next slide, please. So that's how the device works. Hopefully it will place. I don't know. No, it will not play. Let's try it. Let's make it work. No, doesn't work. Okay, so I need to explain you. Unfortunately, for some reason, video doesn't work. So, but On the left side, you see the portable device and the size of radio frequency with a monitor. It is connected with a cable, electric cable or electronic cable to any machine, any fluoroscopy machine with a RUCA board, and it integrates fluoroscopy and imaging. So with this integration, we can understand, appreciate where the beam is going, and including we take a lateral image to understand the depth. And then basically click the button and the energy will be delivered. Next slide, please. We conducted a few studies. This was pilot study, and I joined later, and there was 10-patient study, and results were similar to radio frequency with a significant pain reduction. Next slide, please. Next slide. Same from the study. Next slide. We conducted also MRI after the study that was on 30 patients, and again, you can read it faster than I can read it to you, but it's apparently the MRI did confirm tissue ablations, and it also was it confirmed that the more ablative tissue guaranteed better results. Next slide, please. This is an FDA study was just completed, was done in the United States. It studied just now in preparation to publication. It was 80 patients with 10 roll-in patients, a double-blind randomized control study and sham control study, where sham also was double-blinded. Patient did not know whether they moving from active group to sham or vice versa. Next slide, please. So I will not tell you everything, but just a teaser, right? So the primary hypothesis has been met, and it was shown that in a randomized control fashion that neuralizer treatment is effective. Was 33% difference between groups with odd ratio is 4.3, which is a pretty huge effect size. The more level treated, we had better results. Patients with high NRS had poorly results, and the positive response was also with the patient with higher BMI, which was quite a pleasant surprise. And because radio frequency patient weight is negatively correlated with results. Next slide. So future development, we're developing now next ultrasound guided system, which hopefully will be out there soon. We completed a study on a pig's knee study, and the human study was on the way. There's some study going on sacroiliac joint ablation and neuromodulation. So the future is bright, and sit tight, and hopefully it will come into the United States soon, so you all can join the club and start using high intensity focused ultrasound in your practice. Thank you very much.
Thank you, Dr. Gofeld. Well said. The future is definitely bright and exciting. I'm looking forward to it myself. Next, we have Dr. Amitabh Gulati. He's an anesthesiologist in pain medicine practicing in New York City. He is the director of chronic pain, specializing in interventional cancer pain management at Memorial Sloan Kettering Cancer Center. He is a faculty member of the Weill Cornell Pain Management Fellowship in New York City as the director of the Weill Cornell Pain Fellowship. He is a preeminent educator on ultrasound-guided pain procedures, sympathetic blocks in cancer pain management, and non-invasive neuromodulation techniques. His current research involves the use of high and low intensity frequency ultrasound for the treatment of neuropathic pain. And he's also a Renaissance man. He has his own band, so look out for his next performance. Let's get some applause in the chat for Dr. Amitabh Gulati.
All right, thank you, Jonathan, and thank you, everyone. Do my disclosures. Next slide, please. And I'm going to go to the next slide right now. So, Dr. Gofeld, Dr. Mata have both done a wonderful job of explaining ultrasound energy. We have a whole gamut of energy when it comes to ultrasound. We use imaging, we use low intensity versions of ultrasound and high intensity. And so really you have to understand what sound is to see how you can apply it to the various imaging or therapeutics of ultrasound. When you saw a slide about how the sound waves are going, sound is essentially vibration of atoms. They can vibrate in different frequencies, and some of those frequencies your eardrums can interpret into sound. Some of the frequencies can't do that. What matters is that vibrations are causing motions of atoms, and the more motion or vibration you have of an atom, we think of that in physics as heat. The more something more vibrates, the hotter it is. And so with ultrasound, we can make things hotter. We can make them vibrate. We can make particles vibrate more with an increased intensity of the wave. We can control that with the energy that we send those waves in and the frequency we send it in to a tissue. When it comes to musculoskeletal treatments, using different wave mechanics, we can have different effects. So a lot of us may be familiar with laser therapy, and a lot of us may be using ultrasound therapy, TENS units. And we're asking, well, why would we choose ultrasound versus another modality when it comes to a musculoskeletal injury? And the slides before explain why you might consider ultrasound versus something such as a laser or microwave or something different. The question really, the issue is about penetration of the wave through different kinds of tissues. Dr. Gofeld and Dr. Mata eloquently described the sound wave penetrating muscular tissue and making it to a bony surface, and that bony surface can absorb the sound wave, absorb the vibration, therefore can absorb the heat. Whereas, say you use a laser photons, you're limited in absorption of that photon depending on the wavelength that you choose, usually in a depth of a few centimeters. So what that tells us is that ultrasound for musculoskeletal injury is more useful when you talk about a musculoskeletal, say a ligament or a tendon at the junction of a bone. That's where the therapeutic effect or the heat effect or the vibratory effect will be for ultrasound therapy versus lasers, which will be closer to the skin. This allows us to get a effect for deep structures such as the hamstring, sacroiliac joint, structures that are multiple centimeters deep. And that's how I think about when it comes to ultrasound energy, something at the surface of a bone or close to a bone. And you can control some of these variables. You can see some of these variables on your ultrasound diagnostic machine, your thermal indices, your mechanical indices are actually on your screen, and they tell you how long or how much how much exposure to the soft tissue, how long it will take for it to increase 1 degree centigrade. That will be a thermal indices. You also have mechanical effects with repetitive ultrasound waves. You can have air bubbles near a fascial plane explode with increasing amounts of acoustic energy, and so we can take that into account when causing the different effects of soft tissue. In general, we think about ultrasound energy as increasing temperature, therefore increasing blood flow, hyperemia, and some sort of mechanical effect depending on the intensity that you choose. These are obviously more pronounced when you increase acoustic intensity and you get into high frequency, such as Dr. Goldfeld was talking about, and that will lead to temperatures that are, 55 degrees, 65 degrees, 75 degrees centigrade. But if you reduce that acoustic intensity, we tend to think of that as watts per centimeter squared, but this could be joules as well, depending on the units you choose. If we reduce it, but be higher than a diagnostic device, we can change the temperature to 41 degrees centigrade, 42 degrees centigrade, almost like pulse radio frequency, giving a way of heat to either dissipate or less vibration to maintain the heat in a therapeutic window, but not damage tissue. So next slide. Conventional therapeutic ultrasound has been around for probably many decades at this point. You probably don't see it very often in a pain medicine clinic. You probably see it more commonly in chiropractors, offices, physical therapists, occupational therapists, they're providing these kind of modalities for their treatments. You'll see variations of therapeutic ultrasound. Some of it will be continuous, just like a TENS unit giving you a beam of waves at all times. You can break up those waves with a time of waves and then a delay with no waves and then waves again. That would be a pulse of ultrasound energy. It is conceivable that a continuous amount of energy versus a pulse amount of energy may have a slightly different effect. We tend to want to increase temperature of tissue at a normal kind of rate for chronic injuries, and for acute phase injuries, we might have a pulse version of therapeutic ultrasound. You'll see that our megahertz tends to be 1 to 3 megahertz in frequency, so that the waves can get deeper and deeper through the soft tissue. And you'll see the acoustic intensities being 1 to 3 watts per centimeter squared. To put that in perspective, a diagnostic ultrasound may be 0.6 to 0.8 watt per centimeter squared. Dr. Gofeld's HIFU, you might be reaching in the hundreds or even thousands to thousands of watt per centimeter squared, depending on the technique and the acoustic intensity you're choosing. But our idea of therapeutic ultrasound is to be hyperemic effect around 40 to 45 degrees centigrade. Unlike a radiofrequency needle, which will have a thermal probe, there's no easy way to know the temperature you're getting in a patient. It might have some clinical effect. They might notice the temperature being hot in their skin because this is an ultrasound probe being placed on the skin for multiple minutes of therapeutic modalities. So these are usually 10-minute settings, 15-minute settings, somewhere around there, and usually covering a few inches per centimeter, per inches squared with your therapeutic ultrasound. So the treatments are 15 minutes, and you're hoping for a thermal effect or a mechanical effect. Next slide. I know I only have a few minutes and I have a lot to cover, so I'm probably going to cursory cover the in randomized controlled trials. What I will say is that there's a lot of attempts of comparing ultrasound, whether it's continuous or pulsed, to placebo, which tends to be physical therapy by itself compared to physical therapy plus therapeutic ultrasound. The different settings for the ultrasound machine change the heterogeneity of comparing one study to another, including also, more importantly, what the people are actually targeting. So while you might have a study like this one on knee osteoarthritis, it may be that someone is covering the insertion and the origin site of the medial collateral ligament. Someone is covering the entire joint line. Someone is using continuous ultrasound with a frequency with the acoustic intensity of 1 watt per centimeter squared. Versus someone else is using 3 watts per centimeter squared for 15 minutes as opposed to 10 minutes. There's a lot of variations that make it very difficult to compare one study to another. By and large, you have smaller studies that have some sort of evidence of trends to improvement relative to physical therapy. So this is an example of a group, and a lot of this work has done in Turkey and some of the other countries in Eastern Europe. And in Europe more so than the United States. Nonetheless, you see this effect in musculoskeletal injuries. Next slide. And again, this is the controversy. I mentioned that there's going to be a change in the delivery and the number of days you deliver this device. So deliver the therapy. And I get to my experience probably in 2 minutes. What I will say at this point is the more a patient has an ultrasound therapy, the more likely they are to improve over time. So if you apply this therapy once and expect an improvement in your musculoskeletal injury, that's very unlikely to happen. More likely, you have a continuous treatment once or twice a day. You continue that treatment for 2 to 4 to 6 weeks, and you might have an improvement of your injury relative to physical therapy on its own. That's what we see in our hands. And so you'll see, next slide, you'll actually see regimens that achieve that. And one of the regimens is to provide a home unit, which I'll show you in a couple of slides. This is a meta-analysis using multiple forms of continuous and pulse using ultrasound for knee OA. Again, there's trends in different directions. You might see improvement in patients who have a continuous versus a control. And you might see patients who have an improvement in pulse versus continuous. Nonetheless, you see some trends toward improvement. Next slide. There is evidence using various forms of EMG, nerve conduction velocity, some of these tests, testing the actual activity of muscles that have been contracted because of osteoarthritis in the knee or the quadriceps, for example. And so there is some evidence by applying therapeutic ultrasound, you can recruit more muscles over time, similar to what a tension unit would do in motor type settings. So you can see some evidence electrically that can happen with a treatment. Next slide. You'll see a lot of these ultrasound energy being applied and using techniques of other complementary medicine or techniques. This is a study, it's very interesting, exposing the gel and the skin to the gel and the ultrasound energy, allowing penetration of different minerals through the skin, which otherwise would not happen. And so it's another a study from Turkey showing improvement in knee pain with mineral water or aqua gel with improvement in mineral water. Next slide. This is a meta-analysis. I'm going to go past this and we'll get to nerve regeneration. So next slide. Yeah, next slide. So there's a meta-analysis showing some improvement in pain, marginal improvement in motion, range of motion. And again, this is applying it to therapeutic back with some studies showing some evidence of improvement. Again, some that are also not showing any difference from one treatment to another treatment. So it's a very nebulous field right now, not very well studied in the pain literature. Next slide. And next slide again. And what I will say is, next slide from here, we do have some interesting effects with ultrasound energy. We know we can do thermal damage at higher intensities, but we apply a lower intensity of energy to neural cells. We can see stimulation. We can see regrowth. This is obviously in a rat model in a petri dish of cells that are growing. Again, it's an interesting concept that with the right level of intensities, we can actually have thermal effect to have growth. So next slide, you'll see a density change in, and it's probably hard to see on your slides or your computers, but you can see in number C, you see increase of density of ultrasound based on the, increased density of Schwann cells relative to baseline with an amount of energy that's applied from a device. Next slide. So the animal model does show proliferation of Schwann cells, depending on the technique that you use. We see external regeneration. So there is some hope that energy itself can do this. Is this concept that came out maybe a few years ago, the next slide, led us to do this. I think we skip this next slide after this. And next slide, a lot of slides here. That led us to use this for an interesting concept, which was for chemotherapy-induced peripheral neuropathy. So we have a number of patients that have difficulty walking, difficulty managing their feet-related pain, resultant of mostly cytotoxic agents when it comes to oncologic therapy. We had an opportunity to apply this kind of treatment for our patients. Originally, we applied 2 treatments a week for 6 weeks for patients to find out they're a responder or not. We took all comers of CIPN. We published our early data. It was an interesting kind of event where we eventually ended up with a 3 watt per centimeter squared setting at 3 megahertz. And even though we would think that it would be sufficient with 1 watt or 1 megahertz or even a different acoustic intensity, because now instead of going for a hamstring, for example, we're going for something with the bones right next to the skin. So we think the therapeutic effect is still happening, but the energy is being at the skin and at the dermal layer and at the bony surface, because that's what you have in the foot. So we have patients who do feel the redness, have the erythema after a 15-minute treatment, and you'll see the redness. They'll tell you it's getting warm. Most of our patients now will either buy a device. Next slide, and I can show you a couple of devices that are available. Actually, we don't have that slide, so go back. We have a couple of devices that are available for home use to apply different forms of ultrasound energy. And we've seen some remarkable things happen with repetitive ultrasound stimulation of the feet and now the hands, such that our protocol really at Memorial Sloan Kettering is when they meet our service, they'll actually get LIFU as a first-line treatment for CIPN, which after it has been medical management has either kind of reached its limit or they have failed. We have a whole system in place. It's been remarkable, some of the improvements that we've seen. Now, a lot of this is anecdotal, and a lot of this is, it's going to be case series data. There is our colleagues in University of Alberta have done a randomized control trial, a small one, that has shown some positive effects of ultrasound energy for CIPN patients. So there is some evidence that's prospective in the literature. But we have a large case series now that's probably not in the public not literature at this point that's showing reasonable improvement at least 67% of patients. So next slide. I'm going to switch gears a little bit. And thank our colleagues at Sprint Therapeutics for supporting this. And Dr. Gofeld and myself were actually a part of a evolution of peripheral nerve stimulation, so to speak, or even a revolution, if you want to say. Really finding ways to deliver electrical stimulation on a nerve, but instead of using techniques of either anatomic placement, open surgical placement, fluoroscopic placement. Maybe I don't know if too many people have done CT guided placements, but it turns out that to stimulate a nerve effectively, or to optimize the stimulation, I probably should say, a distance from a nerve does matter. Your device that you're deploying on a nerve and how you deploy it matters. And if you know where your nerve is, and you know its trajectory and its locations, you can optimize the placement of your specific peripheral nerve stimulating device to stimulate that nerve. And this is where ultrasound has really revolutionized delivery of peripheral nerve stimulators. So next slide. A lot of our data is based on TENS units and gate control theory. So either using a motor stimulation or a sensory stimulation to activate your descending inhibitory neurons to reduce the interpretation of your pain fibers, your spinal flamex, your C fibers. There are systems in place in your body, many that's opioid-based, natural opioids, to turn off signaling pathways when you're moving or you're feeling. This is a natural kind of something that's natural for you to have in your body, and we take advantage of that. There's some newer work trying to explain some of the nuances of stimulation, how they might have different kinds of effects in the second order neurons. But my goal here really is, next slide, to just describe how ultrasound has been really helpful. In our hospital, really the application of neuromodulation in the oncology population started with TENS units. Our data is significant. We probably have thousands of patients now, but our early data is presented in literature of using TENS units in patients with treated disease. So patients who had a sarcoma, chordoma of the sacrum, had radiation, probably plus minus surgical treatment, have trouble standing. We would apply TENS units in the area that could feel, could sense. And you would see, next slide, you would see an improvement in pain and a significant improvement in function. So our pain score didn't improve dramatically, but the patients were able to get a increase in function to reach that same pain level. So that was what we realized is a goal-directed therapy with TENS units, and that's how we treat peripheral nerve stimulation similarly. So next slide. There's always concern in oncology when you put electrical waves and ultrasound waves. Am I going to increase the potential of metastatic or increase the cancer load on a patient? One of the concerns we always have is you have untreated disease. If I increase blood flow, do I increase cancer cells growing? Maybe it'll grow in your location of you put the energy. One of the reasons we tend to choose TENS units with sensory stimulation, and they tend not to cause muscle contractions, which increases blood flow. So a lot of us will choose sensory stimulation and sensory settings when using peripheral nerve stimulation to prevent a muscle contraction for just the fear or the concern of potentially increasing blood flow vis-a-vis increasing metastatic disease burden. Logically speaking, it's very hard to do that. Cancers are not just growing because there's increased blood flow. There's a lot of factors to have a metastatic cell grow. But nonetheless, that's the concern. That's what you see in the literature when it comes to concerns about using TENS units, peripheral nerve stimulators, et cetera, in the oncologic population. Next slide. And so this is the data showing that sensory stimulation does not increase blood flow relative to motor stimulation, which does. That's because of contraction of a muscle. Next slide. We have great data work about optimizing why we want to optimize the placement of a peripheral nerve stimulator near a nerve. This is work from our dear friend Rick Rauch, Dr. Rick Rauch, North Carolina, did a lot of seminal work on this subject, really focusing on activating comfortable signaling A beta fast-acting fibers, trying not to activate your A delta or your slow acting fibers or your pain fibers. That was a goal of applying ultrasound to see how close you can get to a nerve to maybe differentiate some of the sensations you will feel. Next slide. What we find really quickly is that A, it's effective to have stimulation over a period of time and have a residual effect. Next slide. B, it seems that there's a magic distance away from a nerve that when you activate your field, your electric field, you might preferentially activate fast-acting fibers before you activate slow-acting fibers. So you might have a pleasant sensation that can turn on and maybe, quote, turn off your pain signaling pathways, for lack of a better way to say this. And that's what we saw in their data. So next slide. We saw that changing the pulse width, keeping a field open for a short period of time, and activating your fast-acting fibers was preferential than having a field open for a long time and having it very close to the nerve or very far away. And this is supported, next slide, with the electrical data. This is modeling data. Now it's 10, 12 years old. There's actually new modeling data. I probably should update these slides a little bit. But this is one of our early modeling data to suggest there's a magic distance, a centimeter, half a centimeter away from a nerve. And this is where ultrasound shines. Ultrasound allows you to achieve those distances and optimize placement of these devices, whether it's a multi-contact or a monopolar type system. You can optimize its placement based on the ultrasound imaging of the nerve and how you approach that nerve with your device. Next slide. We got evidence in oncology that you can have pain relief. These are in the rat model, mammary gland tumor in the tibia, showing that 60 hertz, 120 hertz has some effect in pain relief, and why that effect was happening wasn't necessarily the mu opioid receptor, but the glutamate receptor in this particular case. And so you can see the potentially different effects depending on the frequencies you use. We see that in the animal literature quite readily, actually. That's for a talk at another time. Next slide. I'm going to spend a little bit of time saying how it's been very helpful in oncology. We have plenty of neuropathic injuries, nerve injuries from radiation, tumors, surgery. Treated nerves can have pain from radiation. This is a brachial plexus on the left, on the right side. It has a pancreas tumor around it of a patient who couldn't tolerate opioids. And we were able to place a peripheral nerve stimulator on the brachial plexus and give relief for a palliative patient who passed away 4 months later after implant, but was able to be conversing with her family and have pain relief. She didn't need an opioid. And you'll see that in data for TENS units, for peripheral nerve stimulators, and even stimulators, spinal cord stimulators, reducing the opioid burden on opioid naive patients and actually replacing the opioid in many instances in post and even in acute pain. So next slide, we have interesting techniques in ultrasound to approach different nerve roots, different spaces. A lot of our procedures happen to be focusing on exiting nerve roots from foramina, so extraforaminal space or perivertebral space, even the thoracic spine. A lot of our techniques are using ultrasound to achieve this, and you can confirm these placements under fluoroscopy, which I did on the right. But majority of our patients will be thoracic, and so we place these devices just lateral to the lamina, or even more lateral if you want to get the anterior part of the intercostal innervation. And so variations of placement can have different effects, and also really allows you to do that, whereas fluoro will be very difficult. Also makes placement very easy, and changing of the location of your device to get the exact stimulation parameters that you would like. This is replicated, next slide, by our colleagues using it for different techniques. This is using a low back pain technique, but using it for multiple myeloma patients as opposed to your standard conventional low back pain patients. Again, ultrasound, this is under fluoro. However, ultrasound can also show you the laminas, and you can place these devices accordingly. With that, I hope you left you enough time for some of the other our panelists. I'll pass it off from here. Next slide. Thank you very much.
Well said, Dr. Gulati. Thank you. That definitely answered a lot of my questions on this topic, but also made me ponder some new ones, which reminds me, if anyone in the audience has any questions, just kindly drop them in the Q&A section so we can all learn together. There have been some fantastic questions so far, so please keep them coming. Next, we move on to Dr. Vafi Salmasi. Dr. Salmasi is an assistant professor in the Department of Anesthesiology, Perioperative and Pain Medicine, Division of Pain Medicine at Stanford University School of Medicine. His research focuses on integrating pragmatic comparative effectiveness research with clinical care in perioperative and pain medicine, supported by his NIH funding. He's an active member of the neuromodulation team at Stanford Pain Management Center, where he has established and organizes the multidisciplinary team conference for neuromodulation candidates. His clinical expertise encompasses interventional pain management with particular emphasis on neuromodulation techniques, including spinal cord stimulation and peripheral nerve stimulation, and minimally invasive spine techniques, including basivertebral nerve ablation and percutaneous minimally invasive lumbar decompression. Let's get some applause in the chat for Dr. Salmasi.
Thank you very much, Dr. Paris, for the kind introduction, and many thanks to you for organizing this webinar. So it is impossible to follow Dr. Gofeld and Dr. Gulati. After those really fantastic talks about the LIFU and HIFU, I'm going to just go back to the old boring ultrasound-guided interventions. I'm going to just focus on only 4 because there is a lot more you can do in the cervical region, but I'm going to start with the greater occipital nerve. Next slide, please. The greater occipital nerve, as you all know, is the medial branch, is the branch of the dorsal ramus of C2. It arises between C1 and C2, initially wraps around the obliquus capitis inferior. I assume that I pronounced that name correctly. Then it pokes through and traverses semispinalis capitis and then trapezius and becomes more superficial. Superficially, you can target that with the anatomical landmarks behind the occiput, or you can go to beautiful ultrasound images in the next slide. In this image, you can see that there are 3 muscle layers that you can see between the semispinalis capitis and the obliquus capitis inferior. You can see the greater occipital nerve. In order to get this view, I usually go stepwise. Next slide, please. I start from panel A, where I put the ultrasound probe on the back of the occiput. Then I slowly scan down to see the bifid spinous process. From there, I scan more laterally to see these muscle layers. Between the semispinalis capitis and the OCI, you start seeing the occipital nerve. The occipital nerve is not always visible, especially if there is not a lot of injury or damage to that. In those cases, you might need to focus on the artery that is next to that. If you are doing a block, just infiltrating that fascial layer can achieve a successful block. But of course, if you're doing radiofrequency, you might need to test and make sure that you're close enough to the nerve. As you can see, if you scan lateral and deep enough, you can even see the vertebral artery. In panel D, you can see that. The approach that I learned and I prefer is coming with the needle from lateral to medial. But I've seen people going from medial to lateral. If you go lateral to medial, if you go too deep, you can hit the spine. If you go medial to lateral, if you go too deep, you can hit the vertebral artery. So the key thing is that you need to visualize your needle as you're advancing that. That's the important thing. Next slide, please. The next target is the third occipital nerve and the medial branches. The third occipital is coming from the dorsal ramus of C3. Next slide, please. And the medial branches, as you can see, are coming at the corresponding level. The cervical vertebra, the C1 and C2 are a little bit atypical, but C3 and after that, they are pretty typical. The difference that they have compared to thoracic and lumbar is that you have a smaller transverse process, almost non-existent. The C7 is the only one that has a larger transverse process that you can probably see. Next slide, please. Another structure that you need to be very worried about when you do any intervention in the cervical region is the vertebral artery. The vertebral artery is exposed at the level of C7, but then enters the transverse foramen at C6 and travels inside that transverse foramen canal all the way up to C1. As you can see, between C1 and 2 and at the level of C7, it is pretty exposed. So we need to be very careful when we are doing any interventions in that region. Next slide, please. So going back to the third occipital and the medial branches, when I want to target these for the medial branch block, third occipital nerve block, I usually have the patient in the lateral position. Of course, the procedure side up. I use a linear probe, high frequency. I use either a 25 or 27 gauge needle. My preferred approach is out of plane, going from anterior to posterior. You're going away from the structures that if you hit, you can cause serious damage. You can rotate your probe and get a transverse view and do in-plane approach as well. But out of plane is so easy. These are it's really shallow structures, so it is much easier to do it out of plane. Next slide, please. And of course, whenever you want to target either third occipital or the medial branches, you need to count and you need to find what level you are at. The way that I prefer counting is counting down. There are some literature about counting from the bottom to the top and counting from other structures in the cervical region, but the countdown is super easy. You put your probe on the mass spec process, you slide more posteriorly, then you see the arc of the C1 and then the articular pillar of C2. Then you start scanning down and you see the first joint space, which is C23. Next slide, please. In the same view, you usually see the C23 joint, C34 joint, and the third occipital nerve, C3 medial branch. Sometimes based on how shallow you are, you might even see further down. So you see some peaks and some valleys. The peaks are the facet joints. We can easily target the facet joints in the same view as well. And the valleys are the articular pillars where the medial branches are, and you can target them very easily in the out-of-plane approach here as well. Next slide, please. As I mentioned, and as you come down, you can see other levels as well. Next slide, please. As I mentioned, you can do a transverse approach and go in plane. This is the transverse approach for the third occipital. And as you can see, it is on top of that C23 joint. But I prefer the next slide. Next slide, please. That is the longitudinal view. I just get the same view that I showed you a couple of times and then put the area that I want to target in the middle of my probe so that I can use the line that is on the ultrasound probe as my guide to put my needle in. And I go out of plane, anterior to posterior, get to the target, and inject. Next slide, please. But even though we choose ultrasound to see the nerves better, the visibility of the nerves is not always great when it comes to medial branches and third occipital nerve. This is a fantastic study done more than 10 years ago, published in WAPMU in 2011. And as you can see, the bony anatomy is not visible in probably more than half of the patients, especially when it comes to the C7. But you, of course, say that we don't always go to the nerve. Sometimes we see the bony anatomy rather than the nerve. So next slide, please. In the next slide, you look at the visibility of the bony anatomy, not the nerve itself. And even you can see that about 5% of the patients, even in very experienced hands, did not have visualization of the bony anatomy of the C7. And about another 35%, it was very difficult to visualize C7. Next slide, please. The reason is that as you go down to C7, the transverse process becomes a little bit more prominent. And also you have clavicle that can be in your way of putting your ultrasound in the way that you can have a good visualization of the cervical spine. So as you go down the spine, it gets more challenging to do the ultrasound guided medial branch block. But higher up, you can certainly do that for third occipital and the higher levels of the of the medial branches. Next slide, please. Last but not least, in this short 10-minute time that I have, I'm going to talk about the stellate ganglion block. So as you all know, stellate ganglion is a part of the sympathetic chain. It is at the cervicothoracic junction. We usually target it at C6 because that is the safest target for that. You have the anterior tubercle that is your just protection. You cannot go more posterior to that. There are some people that prefer to use fluoro to mark the C6 and then use ultrasound to do the procedure at that level. That's perfectly fine. I think it is very easy to distinguish between C6 and C7. As you can see, the C6 has the anterior and posterior tubercle. The C7 has a prominent TP, and you can easily distinguish between the two and see how we can target the C6 level. The indications for a stellate ganglion block, you can do that for CRPS or any other kind of sympathetically mediated pain in the upper extremity. Also, the cardiac accelerators are very close in that area of the sympathetic chain. So we can use it for refractory tachycardia. That's one of our most common ICU consults here on the acute pain service. And then newer indications that are being introduced, some case series about chronic fatigue syndrome, long COVID syndrome, PTSD. So those are the things that you might have consults or referrals for doing the stellate ganglion block. So the stellate ganglion is between the longus colli. The fascia plane that I usually inject is between longus colli and the carotid. Next slide, please. I put my probe usually more medially to start from the trachea and then start moving more laterally if I want to inject. One way to inject that is medial to the carotid artery. And it is almost transthyroid. So you go through the thyroid, you inject between the longus colli and the carotid artery. It's usually just shallower and less needle travel, and you're away from most blood vessels in this view. Next slide, please. The small problem that you might have is this kind of pesky small artery called inferior thyroid artery. If you hit that, it can bleed. If it bleeds, it can cause hematoma. And if you cause hematoma in the neck, that's bad. You need to call a surgeon. So for that reason, I prefer the next approach. Next slide, please. I don't want to call a surgeon, so I go way more lateral to these blood vessels. So I come lateral to the IJ, lateral to the carotid to get to that fascial plane between the longus colli and the carotid artery. Sometimes the anterior tubercle in the C6 can be very prominent and be in your way, but you have an ultrasound. You have better visualization. You can scan down, get that out of your way. And as you're advancing your needle, you need to make sure that your needle, you always see your needle, especially in this area. You can compress the IJ. You can just leave it uncompressed and go. Even if you go through and through of the IJ, it is not going to be a big deal. Something that can be uncomfortable for the patient, and you need to probably hold a lot of compression at the end of the procedure if you hit EJ. So you need to look at the skin before entering, because if you hit EJ, then you need to just sit there and just hold compression until it stops bleeding. If you have any trouble with getting the needle in that fascial layer, you can always start hydrodissecting as you get close to that fascial layer. And that hydrodissection helps your needle find a way between the fascia, between the carotid artery and the longus colli. There is one study looking at infiltrating longus colli to see if it is a safe substitute or for this procedure, but that was effective only 50% of the patients. So I wouldn't consider that. I can easily get to that fascia plane. That is a very safe technique. Next slide, please. So how can we incorporate all of these in our practice? Cervical spine is not for the faint of heart. There are a lot of delicate structures there. If you do it safely, you can help your patients tremendously. If you don't do it safely, you can just cause a lot of damage, and the complications are catastrophic. So it is not the area that you learn the ultrasound. Learn the anatomy very well and limit the use to the ones that you are using frequently so that you're mastering that. I don't get a lot of referral for selective nerve root block for ultrasound guidance procedures, so I don't do them. I send them to my colleague, Dr. Otestad, who is just God, or probably a few levels above God in ultrasound. I don't do ultrasound, the RFA with the ultrasound only either, and that's not only my recommendation. I heard the same thing from Dr. Spinner, Dr. Otestad. No RFA with ultrasound only. It is one thing to inject something. It is another thing to actually create a lesion only with ultrasound guidance in such a delicate area. And know your limitations. If you feel that you're getting in an uncomfortable territory, stop. All our procedures are elective. You don't need to necessarily harm a patient to do that. And the last thing is that there is a chance that you get lost. You reach out, you take your eye off of the monitor, you reach out to get your local, or someone distracts you and you lose your beautiful view that you have. In these cases, start over. If you're doing occipital, go all the way back to the occiput. If you're doing just the medial branch block or third occipital, go all the way back to mastoid. So start over to reorient yourself rather than just blindly scanning in that region. And that's all I have. Thank you very much. Back to you, Dr. Paris.
Great job, Dr. Salmasi. Definitely some great clinical pearls towards the end there. Thank you again. And last but not least, we move on to Dr. Qing Ruan. Dr. Ruan is a highly accomplished anesthesiologist and interventional pain medicine physician. He completed his pain fellowship with Dr. Gulati at Cornell and is currently an attending anesthesiologist and pain physician at Providence VA Medical Center, holding an appointment of clinical instructor at the Warren Alpert Medical School at Brown. Please welcome Dr. Ruan.
Thank you, Jonathan, for that introduction. I'm probably one of the younger members of the panel, so really appreciate the opportunity to be here speaking to all of you. So I think coming from my angle, we're going back really to the basics of ultrasound guided procedures and interventions. Having a background in anesthesiology, makes regional ultrasound and interventions pretty familiar. And Dr. Salmasi has pointed out, the most important thing that obviously with these interventions start at a level that's most comfortable for you. And I'm just going to talk about a couple of very basic procedures that could be done under ultrasound, which would be suitable for individuals like myself, who's just graduated from fellowship, just slightly more than a year ago. And for residents and fellows, these might be, the right kind of interventions to go into as you, gain your experiences. So really the first one to talk about is the superior cluneal nerve block. So just sort of a little background regarding the anatomy of the area. So obviously, the origin of the nerves, lateral cutaneous branches of the dorsal rami, some literature says L1 to L3, others say, T12 to L5. And essentially it covers, the sensory innervation or distribution to the posterior iliac crest, around the superior gluteal regions, and some others also say that it extends towards the greater trochanter. And so, you can kind of understand that the nerve bundle in the area is actually a little more complex than you understand, because, purely the superior cluneal nerve itself kind of breaks up into three different individual nerves, and they kind of grow into this osteofibrous tunnel. And most of the time, it's the medial branch that gets trapped in there. And I believe literature points out that 55% of the time, that's the obstruction or occlusion within the osteofibrous tunnel that causes pain. So, what we're looking for on the ultrasound will be this tunnel. So what you actually start with is you look for, osseous targets. First of all, patients will be prone, and you scan to look for the posterior inferior iliac spine. And at the top right-hand corner, that's what you will be looking for. So what's jutting out and making it pretty obvious for you is the bony protuberance, and that will be the posterior inferior iliac spine. Lying right above that is the gluteus maximus. So having found the anatomical structure, you kind of continue to slide the ultrasound probe more cephalad and more lateral. And then what you encounter will be the second picture on the right side. This is when you start looking for the osteofibrous tunnel or the fatty tunnel. What will come into view replacing the gluteus maximus will be the gluteus medius. And as you can see, there's encircled in those green lines. So that's the thoracolumbar fascia. And what's right inferior to that is the erectus spinae. So those are sort of the musculofascial components to this tunnel. And just to the right side of that, that is the iliac crest. So, now you've found all the structures that encases this fatty tunnel, and that will be, the exact location that's pointed out by a little red dot there. That will be your ultrasound target. So you'll be coming in lateral to medial looking for that target. Next slide, please. So essentially, what you should be looking out for would be your needle penetrating several layers. So the skin, subcu, fat, the gluteus medius, thoracolumbar fascia. You probably wouldn't penetrate the erectus spinae because that makes up, that tunnel that I was just talking about earlier. I just put it there so that, it completes the picture of that tunnel. The extension of the superior gluteal artery towards the iliac crest that you have to be a little wary of when you're scanning. If you're a little too low, the artery might come into view, so always throw the Doppler on when you're unsure. Next slide, please. So the next relatively simple target would be the lumbar facet injections, or essentially the medial branch blocks. So in order to optimize the views, as it's pretty well illustrated on the right side that you start off again, with the patient in the prone position. Always start midline with your ultrasound probe held in this longitudinal view. And it's pretty clear that when you're midline, the spinous processes kind of travel towards the ultrasound probe, and it's being pointed out quite nicely there in the picture on the right side, the L4 and the L5 spinous processes being the closest to the probe. And that is a spectacular picture because it actually even shows you, the dura, both the dorsal and also the ventral dura. And if you were to slide the probe more laterally, what it's going to show is that the spinous processes will migrate and become sort of sawtooth shaped. And that actually shows the lamina or camel hump, and if you were to sort of count down, you'll see that it's L4, 5, and you see a little divot right before you come to the sacrum, and there's actually the foramen. So now that you've kind of decided which level you're going to go at, now you're going to turn the probe 90 degrees and go into the transverse view. Next slide, please. So once you've achieved the transverse view, you'll be looking for the spinous process window. So again, that's what the top right-hand corner picture shows. That's when your probe is against lamina, and the structure that's the closest to you will be the spinous process. Following that down, you'll review the lamina, and then everything becomes a little bit of a blur. What's most anterior is the vertebral body. And so in that position, you kind of tilt the probe back and forth. You might have to slide it up and down to then enter what's called the interlaminar window. So this is the window that you should be achieving before you place your needle. So this is the most superficial hyperechoic structure that's gonna be pointing towards the probe, changes from the spinous process to become the interspinous ligament, and then traveling further down, things will start to look a little more familiar for the individuals that's done this multiple times under fluoroscopy. So you start seeing the SAP coming into view, and then more anterior to that, the transverse process. So exactly the same as how you would perform the procedure under fluoroscopy. You'll be aiming at the point or the junction between the TP and the SAP. Next slide, please. So for lumbar facet joint injections, again, the layers of tissue that you'll be penetrating starts with the skin, subacute fat, erector spinae, and multifidus. So these are all just the paraspinal muscles. The things to avoid, so the dorsal rami of the spinal nerves, obviously, avoid deep injections. If you're traveling to medial, it could mean that you're passing through a foramen and you're going to be injecting too close to the nerve, or you're going to be doing an intraneural injection. There will be lots of segmental arteries and veins around the area, so it's always a good idea to throw on the Doppler and just check before you inject anything into the area. The risk of intravascular injection is obviously the biggest thing that we want to avoid. So don't be too shy to throw the Doppler on. Next slide, please. All right, so the third sort of simple and straightforward injection that you could try would be the caudal epidural. So once again, patients in a prone position, and you throw the ultrasound probe on, and what you'll be identifying will be, what looks like frog eyes, or essentially, it's the sacral conua that's pointing out. And what's in between is the sacrococcygeal ligament. That's the picture again, represents a very nice view of that area. Once you've found that level with anatomical structures that look like that, what you do is you turn the probe 90 degrees, and that's when you start placing your needle. Next slide, please. So once you place your needle, you should be looking for this view, and the sacrococcygeal ligament should be apparent to you. This looks very obvious because it's a nice picture. It looks like the epidural space is wide open, but it's not always the same, especially in older patients where there's a lot of ossification in the area, and it's not that easy to deliver the needle into the epidural space. Once you're in that space, do be very careful because there's lots of sort of vascular structures around the area, including lots of venous plexuses. Some people do this procedure again under dual ultrasound and fluoroscopy. So what they do is that they place the needle there and they inject contrast and they take a picture with the X-ray just to be sure that there's no intravascular injection before they deliver the medication. Next slide, please. And the final injection, the sacroiliac joint injection, actually starts with a view that's very similar to the caudal epidural. So again, find midline, find your sacral conua, and then obviously, slide to the side that you're injecting your medication in. So whether it's the left or the right, slide in that direction and then slightly cephalad. So always keep the sacrum as the floor and have it visible on your ultrasound probe while you seek the iliac crest that's going to be coming into view on the lateral side of the screen. So once you've found that and you have both the ilium and the sacral floor in the same view, what you should be trying to do is to find the hiatus in the middle, which will suggest that that's the sacroiliac joint. So obviously there's lots of fibrous elements overlying that joint, various different ligaments. So sacroiliac, sacrotuberous, sacrospinous ligaments. So imagine yourself delivering medication through those ligaments, and that will be the target of your needle. So aim for that hiatus between the ilium and the sacrum. Next slide, please. So the important thing here will be identifying the ilium because that can actually be a little, tricky sometimes. So you can see in the ultrasound image on the right-hand side that, this is obviously a right-sided joint with the ilium on the right side of the screen. But if scanning is not performed correctly and your probe is too medial, the sacrum could look like it's riding up and you could think that that's the ilium. And the little divot that you see that's sort of coming into view right before the sacrum is actually a sacral foramen. So you have to be a little careful when you're injecting, ensuring, that you're delivering medication into the joint instead of into a sacral foramen. And other structures that could also occlude your view or your injection would be the gluteal artery that could rise up pretty close to the inferior edge of the sacroiliac joint. Next slide, please. So this is the picture that actually shows that. So you have the superior gluteal artery sort of traveling more laterally, but there could be branches riding up into the sacroiliac joint, such as here. It's suggested that the posterior branch of the superior gluteal artery could be sort of winding its way up towards the inferior edge of the joint. So be very careful there. Once again, whenever you're unsure, throw on the Doppler and have a look before injecting. So yeah, as I was saying, coming from the angle of someone who's just graduated over a year ago and performing your own injections, being accountable, for the outcomes of your injections, starting at the lumbosacral level, that's a pretty good bet. And obviously, go very slow, throw on the Doppler all the time, ensuring that you get your injections right. Select a couple of injections that you're comfortable with. And this area is pretty safe. And I will recommend anyone new to start with these. Right. Thank you.
All right, well said, Dr. Ruan. Way to finish off strong. So that concludes the lecture portion of this webinar. Unfortunately, we are a bit over the time that we wanted to be. We will have to send some answers to the questions in the chat individually. But on behalf of PSPS and WAPMU and our incredible panel, want to thank everyone for joining us tonight. The exchange of ideas and clinical wisdom shared here has truly been inspiring. We hope you gained some valuable knowledge and fresh perspective on the evolving field of ultrasound technology. A heartfelt thank you to our speakers for their time and their expertise, and to you, our engaged audience, for your thoughtful questions and your energy. Lastly, thank you to our sponsors at Sprint Therapeutics. Keep an eye out for future webinars and educational content from PSPS and WAPMU. Be sure to join us at the upcoming conferences. WAPMU is going to be August 8th through 9th in Chicago, and PSPS is going to be September 18th through 20th in Las Vegas. Until then, stay curious, stay connected, and have a safe and relaxing evening. Thank you.